Okay, welcome back, folks. This is our second video having to do with snapshot 12 lead ECGs. And this is a 10-second ECG from a patient. We named him MT Chambers. You'll see there at the upper left. And he's a 39-year-old male. And that's not his real name, and you'll see why we named him that at a later time. Let's look at his conventional 12-lead ECG. He has a sinus bradycardia with a heart rate of about 50 beats per minute. And the automated program calls abnormal repolarization, possibly non-specific. And you can see that out here, especially in the lateral precordial leads V5 and V6, where the T wave looks flipped. And sort of biphasic also in the lateral leads 1 and AVL. So non-specifically abnormal, but looking at this ECG, I see a couple of other abnormalities. There's a little artifact in V2, but I think that's just artifact. But if we look at the voltage in lead V3, for example, and count that up, 5, 10, 15, 20, and we add that to another 5 at AVL, we're actually over 25, and so we meet just barely the Cornell voltage criteria for LVH, or left ventricular hypertrophy. We don't quite have Sokolov-Lyon voltage criteria for LVH here. If we look at the maximum V4, V5, V6, and add that voltage up and add it to the S-wave voltage in V1, we don't make it for Sokolov-Lyon voltage criteria for a male. But he does have borderline Cornell voltage for LVH. Let's go on over and look at our advanced ECG. We're looking at our fiducial points first. Over here on the right, we see the P beginning and peak and end, QRS beginning and peak and end, and T peak and end. All of those fiducial points look pretty good to me. So we'll go ahead and trust our results that we're in the right places. If we go over and look at some of the parameters now from the 3D ECG application, we see right away that we're flagging on the spatial mean QRST angle and also on the peaks. They're both well over 100. And that Cornell voltage, as we saw, is just barely into abnormal range for a male, just over 2.5. Product sort of follows along. Let's go and look at some of the loops. Remember, in the last guy, we had a frontal plane QRS maximum that was too far to the left. This one's okay. If we look in the horizontal or transverse plane, we see things that are a little posterior directed for the QRS loop, and the horizontal T max vector, the white loop there, is too far anteriorly directed. That's flagging. And so we have a part of the reason for our big angle. The sagittal plane looks sort of non-specifically abnormal to me. Also a big spread between the QRS and T loop locations. So there's the ventricular gradient. Horizontal elevation is also flagging, so some directional changes as well, or abnormalities in the 3D ECG. Let's go ahead and look at the other application we can look at, which is the T wave and QRS wave complexity or morphology. And we can see that we are flagging in terms of the T wave complexity. We have an abnormal couple of ratios there, not the PCA ratio, which is normal, but we can see a couple of the other ratios that we calculate are abnormal. And therefore, we also have overall abnormal T wave complexity. So if we look at the T wave complexity and the abnormal three-dimensional ECG, we have an abnormal recording. We don't know exactly what we have here. We will go ahead though and eventually allow our statistics to help us with determining what the underlying condition is here, just like with the other patients that we've examined so far.